I love having conversations with patient advocates. They always speak their mind. I'm about to sit down with one that is a bit of a rare bird. Not only has she been an advocate for many, many years, she is also an accomplished comms and marketing professional. I've been wanting to interview her for a while now, and I'm excited that it's happening today. You are about to watch my conversation with speaker, author, and caregiver Sue Robbins. Let's get to it.
Sway help.
Sue, welcome to the program.
Thank you for having me. I appreciate being asked to talk about my work.
Yeah, it's always fun to, we haven't spoken in person in a long time, but, always a pleasure to talk to you about the work you're doing and very curious to learn about the work you're doing, especially in the patient experience space. But maybe just before we dive in, Sue, can you give our audience a little bit about yourself, your work, and and tell us a little bit more.
Sure. Well, my name's Sue Robbins. I live on the west coast of Canada. I, I consider myself a healthcare advocate, both as a patient and a caregiver. Um, I've worked in healthcare my entire career, but not as a clinician. Um, and I always think about why I started to begin with. That's really important to me. And I would say it started, gosh, I can't believe I'm saying this, but like 40 years ago, I was in nursing school and I ended up dropping out and transferring into English and getting a degree in Shakespeare, which, of course, you can imagine how happy that made my parents. It's not necessarily the most practical degree in the late 80s, but I had an interesting experience in nursing training. I was about halfway through before I transferred out, and I ended up staying in healthcare my entire career. But I worked as like a unit clerk and a staffing coordinator. I started work for the Department of Health and worked in their funding and costing unit. So I had this like very interesting broad perspective of healthcare. And then it became personal 22 years ago when my third child, my youngest son Aaron, was born and diagnosed with Down syndrome. And a lot of people don't realize, and I didn't realize it at the time either, that especially kids with Down syndrome have a lot of medical needs. It's not just an intellectual disability. So really that immersed me in the world of pediatric healthcare, children's health, rehab therapy, all that kind of thing while I was caring for Aaron. And then, so I became very involved. I started working for Children's Hospital Engagement, and I moved out here to Vancouver in a similar position with BC Children's Hospital and Family Engagement. But then 7 years ago, I got breast cancer. And so I was diagnosed with breast cancer and I went through treatment. And so lucky me, I now have a patient experience in healthcare. So that's my why, I think, has to do with my background to bring me to this point. And I've written a couple books and I do consulting for a living. And I do a lot of public speaking. I enjoy speaking to healthcare organizations and to patients to help them craft their stories for change. Because I have this English degree, that storytelling is really, really important to me.
Well, and Sue, what's the kind of work that you do? You were explaining it to me before, and I found it fascinating.
Um, well, I do like, so I did write a couple books, but really books are just tools to get your message across more than anything else. So I do consulting with healthcare organizations about best practice in patient engagement and also patient experience. I've actually got a client in South Australia that's very interested in improving the patient experience. So I help guide them. That's what I consider myself. I do quite a bit of coaching to just really encourage direct people to resources, best practice, how important storytelling is, I think, in this work. So I work with orgs, and then I also work with patients and patient groups to help. Often patients have really long stories to tell, but if they get asked to speak at an event or a conference, I help them kind of tease out the three key messages and the takeaways, all those good communication marketing things that you well know about. And so I do workshops for patients to help them craft their stories for meaningful change. So that's what I do for a living. And also I co-own a health communications company called Comm that's in Vancouver and Edmonton. And we work a lot with the public sector. We're doing animations and videos and really helping bring creativity into healthcare, because I like to talk about the humanities in healthcare. And I think bringing the arts into healthcare is a way to do that.
Well, I mean, you just hit on one of the many reasons why I wanted to get you on the program. One, patient advocacy, something you've been doing for a long time, but you also mix in the storytelling, the marketing side, and the communication side. So you have both perspectives, which is exactly the perspective of our audience here at Sway. So I'm looking forward to this.
Mm.
So, so Sue, right off the bat, let me ask you, this is something I've been asking a lot of my guests recently, in this space. You know, what's your current opinion on the state of patient engagement and patient experience in healthcare? Like, are we doing well? Where are we not doing well? Can you give us some perspective on
Mm.
that?
Okay, that's a loaded question for sure. And so I'll try to be balanced here and not too cynical, because I have been doing straight advocacy work for about 20 years, and I do get discouraged when we talk about progress and improvement. Sometimes that doesn't mean positive progress and improvement for patients and caregivers. And I think the needle in both engagement and experience has moved backwards since 2020, since the beginning of the pandemic. And, I see less and less patients at the boardroom table where decisions are being made, or behind the podium at healthcare conferences. I feel as if the organizers have gone back to professionalizing things. And I think that's because during COVID, early COVID, they kind of went back to this expert command and control model where it was very authoritarian and top down, and that's how the decisions were being made. And it wasn't so much from the local level. And so us patients were very passive, we did what we were told. And really, I think we lost some of our influence and power. I don't know if you feel the same way. Maybe I'm just kind of making this up. In some sectors, in other sectors, there has been progress, like in research, in particular in Canada. And that's because our big funding agency here, they don't mandate including patients, but I know that it's strongly encouraged in the research sector. So I have seen some growth that way. But at the clinical operational level, the idea of bringing in the patient voice, I think our progress has slid backwards. That's my feeling, anyways. And the professionalization piece is, I was hired as a family member, like as a mom who only had an undergraduate degree, into a hospital environment to do outreach with families and bring their voices in. And now I see that, folks who maybe don't have lived experience and have graduate degrees, they're the ones that are being hired instead. So I worry that especially the patient engagement and the patient experience world is kind of being hijacked away from the idea of it should be delivered by people who have had that experience. Like, I feel that strongly, and I see that we've also slid backwards with that too. That wasn't very
Yeah, I think
balanced, but I'm a bit disheartened, to be truthful.
no, hey, and that's a valid opinion. I don't think you're wrong, for sure. I think after COVID, there was definitely a decline in involvement of patients on the healthcare provider side, because
Mm,
you're right, they went back to a command and control because they had to, right, during the
right, right.
pandemic. And maybe we're still carrying the momentum of that. Now, some organizations are doing much better than others, like
Right.
getting back to where they were pre-pandemic. But it's
Mm-hmm.
interesting. I am interested in diving a little bit deeper on the statement you just made around the professionalization of,
Mm.
and perhaps that organizations are not bringing in people with lived experience as much and just going with professionals, if you will. Do you want to hazard a guess as to why that is? Is it just because they can't find them, maybe, or is it
Oh
more?
no,
No,
there's
no,
like
okay,
lots of patients that are looking for paid work. I probably get DMs on LinkedIn like twice a week from folks who are doing patient advocacy. They're doing engagement work and they want to do it as paid work. And
right.
I can tell you, I'm kind of like a grandma of this whole thing. I'm literally a grandma. I've got two grandsons. My daughter is a RN actually, and she had two babies recently. But I feel as if I can't. I don't have a living doing this patient engagement work, and I've been around for a long, long time, and so I think that opportunities for paid positions are very rare. And I've noticed, they do come up, but they're almost always full-time. So that is a tricky thing. And to me, that immediately excludes a lot of patients and caregivers, because the reason I left the Children's Hospital here in BC, 8 years ago, it was before I was diagnosed with cancer, it was because I needed flexible work in order to care for my son. So I think whenever I see a job pop up and people are like, oh, you should apply for this, this looks great, and then it's full time, I'm like, I just can't. There's no way I'm able to do this. And I think that is a very clever way of excluding people with lived experience, because our lives don't allow us to apply. And it used to be the one thing is good is that now a lot of it's work from home. And before the pandemic, I worked from home, but that was pretty much unheard of. So it does make it a little more flexible. But I think the full-time thing, and I think too, orgs, they like to have people who are like them. So people hire people who've been to school a long time, who are so-called smart, like academically. It makes them feel comfortable. And I think sometimes patients, especially folks who are lay people, make the people sitting around the boardroom uncomfortable because they're not like them. And I think that's a big problem. And that speaks to the lack of diversity that we've got at the decision-making tables. But that's a whole other thing.
Well, I take one sort of silver lining in the fact that there are some jobs, right?
Yes,
that
there
they're
are some
hiring for,
jobs. Yes.
right?
Yeah.
Hiring for patient experience people.
Right.
But unfortunately, it sounds like that maybe it is biased against people who have lived experience or who are living it, because they aren't able to do full-time work, right? They need that flexibility in terms of the hours, but also flexibility in terms of location. Okay, all right. When organizations do engage patients, people with lived experiences, you hinted at it there. What are some of those follow-on benefits? Like, what happens when they do engage? Like, what are some of the things that they see? What are the improvements that can be made?
Well, I wish there was more research about this, believe me, because I get asked this question every time I do a talk. There has been some research that says patient engagement does improve in the end, patient outcomes. It improves quality, improves safety. And really, I mean, you and I are both communications people, right? Like, the number one thing about communications is before you engage with someone, you need to understand them well. So there's so much that healthcare does that is about educating patients, reaching out to patients, telling patients to come for their screenings, like all this kind of communication that goes out to patients, but it's often just one-way pushed communication. And I think unless you have patients involved with you, you don't know what patients really want or need. You're making a lot of assumptions. And I think that's why a lot of information sharing efforts and public health efforts, they fall flat, because they don't have a very good understanding of patients, or they do this thing which kind of infuriates me, that says, they go like, we're all patients, so everyone's been to the doctor, so we'll make the decision, without, they forget that they come with if you're a healthcare professional, you come with a boatload of privilege when you go to your own doctor, and some insider knowledge. And really, if you're trying to communicate with like folks that are so-called hard to reach, which, they're there, right? You just haven't tried hard enough to reach them. Then I think the only way you can do that properly is by talking to those people and asking them what they need and want. So I believe it's a miss, actually. It's a miss unless you have folks. You should have the same people around your table as who are sitting in your waiting room, or even better, people who haven't even been able to make it to your waiting room, right? Like, so it's not just those who are in healthcare. There's a lot of people that can't access family doctors, and really finding out more and being curious about them, I think, is really, really important.
Yeah, I think the analogy I use a lot is, Procter and Gamble would never think about putting together a new laundry detergent or a laundry detergent ad without getting a bunch of laundry, moms in the room, right?
Right,
Because
right.
that's
Focus group.
typically
Yeah, yeah,
right, a
yeah.
focus group to inform it. Yet but I would also argue that yes, we've all done laundry. Like, I've done
Yes,
laundry,
yes,
but
yeah, that's right.
I would not consider myself a good target because I don't do it that often. Probably should do it more often, but
Mm.
um uh, but but it's the same with yes, we're all patients,
Yeah,
but I am an episodic patient. Like I'm fortunate enough to have to only go to the doctor when I need it, or for my regular checkup, and that's it. So yes, I am
Mm,
a patient, but I am nowhere the same as someone who has multiple chronic conditions, has to
right.
see 17 specialists. Like
Mm,
that's not the same. I don't have that
right.
experience, right?
Right, right.
And so
And
for
I think
me to
all
make a such,
experiences are important. I don't want
sure.
to I don't want to discount the person with the broken leg that goes to emergency department. Like I think that part is important, and I'm sure they have good feedback, constructive feedback about that particular experience. I think, but I just think a lot of us who are kind of been doing this a long time. My son has Down syndrome. He's always going to have Down syndrome. He's always going to need support in the healthcare system. And so we just are invested in it in a different kind of way. I think because of that, it doesn't mean that our feedback is better, but I just think we have a chance not just to reflect at point of care at that particular time, but to reflect back about what has happened over time. My first book's called Bird's Eye View. So, we've got this bird's eye view and we reflect back over time, and we folks might have some wisdom that the so-called experts have never even thought of before. And I've seen that anecdotally around the boardroom table when they bring in patients, like say for, can I give an example? I'm kind of
Yeah,
like,
for sure.
okay, so it was like, I was involved with a group. They were redoing an emergency department at Children's Hospital, and they brought in a couple of, happened to be moms, to give feedback about what they needed when they brought their kid in for emergency. And one of the moms, and this was over 10 years ago, said, it would be good to have like plugins for our phones. Like even back then, I mean, nowadays it's kind of, and back then that wasn't really a thing. You couldn't find a plugin for your phone if you're sitting there for 10 hours. You need to charge your phone, right? And like the professionals didn't think of that at the time, but it was a mom who came in and did that. And similarly, I remember this is way long ago, like 15 years ago, the only Wi-Fi you could get in the hospital was clinicians. Like if you were a member of the public, you couldn't access Wi-Fi because they made a priority for clinical reasons, not for like the public or patients or youth. And really, I remember my husband went in and talked to them about, he happens to be an IT guy, as a dad, when his kid's in the hospital, how he needs to work, right? And how important it is for him to have Wi-Fi, and really how that his voice helped change the system in the hospital. And finally they allowed Wi-Fi. I mean, it sounds silly now, like in 2025, but back then it was quite unusual. So I just think that different perspective can bring in, we have good ideas. That's what I think patients do. All kinds of patients do.
Well, and back to what you said about outcomes, right? Like I know it's sort of very simplistic to say, but hey, when you have Wi-Fi, when you feel connected, you can talk to the loved one as you're waiting. Stress goes down, right?
Right. Yeah.
You're less likely to be agitated when talking with that frontline person because you've been able to do some work, you've been able to connect with family members and so forth. So there are some immediate benefits to this, but you may not have realized that until someone brings it up who's been sitting there for, or gone through the experience of sitting there for 10 hours unconnected with the outside world, watching their phone battery die, right? So,
Right, right.
um,
Yeah. And I know I work with a CEO in Australia, and she's on a project to improve the emergency department waiting room there. And she said she was going to go to different hospitals where she wasn't known and sit in the waiting room. And that's not the same thing as actually a patient experience, because when we go to emergency, we're like totally whacked out with stress. We're in pain. We're worried about ourselves or our loved ones. Like there's lots of other things going on. But even that simple act, I think, of going to try to get a feeling of the experience of what it feels like to sit in an emergency room, a lot of health administrators don't even bother to do that. So they have people who brief them about it. But one of the best examples I ever had was at a children's hospital. There was a new family center care manager who started up, and she shadowed a family who had a number of clinic appointments at the very beginning of her job for an entire day, so she could just kind of have a feel of what it felt like. And of course she spoke with the mom and the child as she went along. And I think the more we can feel compassion for the people that we're caring for and serving, the better. And so there are really easy ways to do that. It doesn't need to be all around the boardroom table.
Well, actually, that you led me right to my next question, which, you mentioned a couple of these practical ways that people and healthcare organizations in particular can engage patients in meaningful ways. You mentioned, obviously having them on a committee, a council, a PFAC, having them around the boardroom table, and then also, stepping into their shoes for even for a moment, right? By visiting the waiting rooms and so forth. Are there any other practical tips that you can share of how to maybe engage patients a little bit better?
Um, I think it sounds very simplistic, but asking people is really important. I think healthcare organizations collect a lot of data, but then nothing is actually done with it. I think patient experience needs to be wrapped up with quality improvement. I don't think you can I don't think you can improve your quality unless you understand that experience. And like I said, it shouldn't, it can go beyond surveys. And what I talk about, when I say ask patients, it's not about asking them to come to you. It's about really committing to outreach and going out to the community where the people are and talking to them on their own turf. Not everyone is comfortable around a boardroom table or on a Zoom call. Not everyone has, like, we should not make any assumptions. People have laptops, like an internet to be able to connect up. So if I had a magic wand, I would wish that both patient experience and patient engagement people would think about going out to the people they serve instead of expecting them to come to them. And I did a lot of that work when I was kind of like a go between the hospital and the families. And I would meet for coffee and I'd meet for lunch and I'd go to people's homes. And I think that there's value in it. And if you're not doing outreach, to sit and listen to people, and the key is this is relational work, it's not transactional. So if you want to get away from the tokenism and the checkbox mentality, you actually have to get to know people as human beings. And you only do that one-on-one with time, I think. I really believe strong in that. I worry we're getting further away from that as well.
So really truly meeting patients where they are, whether that's, if
Mm.
they're homebound or even a local coffee shop or the church,
Yes.
instead of making them come to the hospital where essentially you have home field advantage, right? Like
Oh, who wants to go to a hospital? I'm sorry. I can't even, I went to the cancer hospital, and when I go back for appointments, I can't even park in the parkade. Like, it sounds kind of, but I've got so much medical PTSD about what my cancer treatment was like that the idea of going into that parkade just brings me right back to that place. So I actually have to park far away and walk in order to do that. And I'm not the only one that avoids hospitals if at all possible. If you work there, it seems like normal. You get up and go there every day. But for patients, like, it's not our favorite place to be. I can tell you that much. But yes, neutral ground, or better, why not? Like, if I've been to many families' homes with permit, it's something that I've been invited as a guest to their home, and you get to know somebody in a different way than you would when there's on a Zoom call or sitting around a table. So I really believe in the outreach model. I think that's how you start with diversifying your patient engagement. And as far as the kind of projects you do, I think the patients can tell you. And in my experience, physical space is a really easy one to pluck off. People kind of understand it. It's bricks and mortar. And so, yeah, maybe you're looking at your emergency department and is there enough plugs? And this might sound like simple things. Is there a warm blanket warmer? That one's really important to me. I talk about warm blankets a lot. Can you show patients where the warm blankets are so that they're able to access one their own without, counting on staff? So, seemingly simple things like that, I think, can help make healthcare a better place. It's not just about patients and our satisfaction. I know once I did a talk at a conference and someone said, "You patients just want hotel service. That's all you're looking for." And I said, but it's better for you if we're not, as you said, so agitated. And we don't have to, we don't get our questions answered. So we end up coming back to the system. I think that it ends up costing more money. It's not about hotel service. It's about creating healing spaces. I think healthcare should be about healing more than anything else. So any way you can affect that, I think, is a good thing.
Yeah, I just got off another interview where we talked about you can't disassociate staff experience from patient experience because
Yes, I believe that
when
too.
one is bad, the other gets affected, right?
Yeah, they're
Either way, like
intertwined. You cannot, you
you're-
can't, it's like both ways, like it's both ways. So yes, and I wish, we talk so much about staff morale now. I know that that's a big hot topic. I wish they would invite patients into those conversations too, not just because staff morale affects my experience, which it does, but because I also, especially if I have longer term relationships, I care about the people who care for me. Like if this is really relational work, it's a mutual two-way thing. And I think that patients also might have good ideas about it, and they probably are quite intertwined.
Yeah, I mean, just as something as simple as, one time I observed that this frontline person who was taking in registering patients was sitting in what I would call a Frankenstein chair, right?
Mm.
It was a chair that looked like it would be made out of four other chairs, cobbled together, and it was clearly uncomfortable. It was
Yes.
crooked. And I'm
Yeah.
just like, how can that person be expected to deliver a good patient experience when they're sitting in an uncomfortable
Right.
chair for six
Right.
and a half hours, right? Like,
Right. Right.
like that's just so so yes, they are intertwined. That's a sort of very pedantic example, but it is, and I think you're right. I mean, if you invite some patients in, they will probably have some pretty good ideas to
Right.
help the staff care for them a little
Right.
bit.
Yeah. Yeah.
So
So I'm
so
always like, I've got two messages. I've got healthcare and humanity, humanity and healthcare for us all. And also we're better together. Those are the two things that I keep beating on my drum for so long. I've kind of distilled it down to those two things. So the better together part is really important. If you're not inviting the patient voice to your conference, to your event, you're missing a huge part of the experience. I really feel strongly about that. So together, we need to do it together. That's the only way positive change is going to happen.
I'm going to catch up on that question in a second,
Yeah.
but just to go back a little bit, um, you mentioned that physical plant design is a fairly easy way to engage patients. I think everyone understands layouts and things like that. But in your mind, Sue, what should be the top priority right now in terms of patient engagement? Like, is there a particular area that you look at and go, man, we really need to do more in this particular area? Like, is it patient communications? Is it access to care? Is it care at home? Like, is there an area that you're just like, wow, we need more work here?
Oh boy, that's a big one. It's everything. If I can say I mean, if you can't access care, there is no health care to begin with. So probably, here in Canada, it'd probably be good to go back to the Canada Health Act and think about, the fact that one of the foundations is access to care, and many people do not have a family physician and have to visit walk-in clinics if they can find them, or end up in an emergency, which is not the best patient experience to begin with. Um, I, you know, I want to go back to stories. I think, and I want to go back to students. I think if we back up the truck quite a bit, like I can't affect, I was thinking about serenity prayer and what I can affect and what I can't affect. So I can't affect the way students, for instance, I think about my daughter, she went into nursing, and the grades you need for nursing are out of this world. Like compared to when I was in nursing, you kind of need like medical student grades, like you need 90 plus in order to get into program. But she wasn't, there was no interviews even. It was just based on academic. So I just think I worry that even our new generation of health professionals have not been exposed to the real life of patients. And I think the more that we can get patients telling their stories and involved with their teaching in front of them, the better. Like I think we need to do preemptive type thing, so that we can encourage that compassion that we were talking about. And someone wise once said to me, even if you don't understand me because I'm quite a bit different than you, it doesn't mean that you can't respect me. So I think that people really, I think the more we can introduce the idea of stories and people sharing their experiences and not being dismissed or minimized or being called a complainer when we have constructive feedback, the better.
What you're saying is there's no one particular area. We just need to get more involvement from patients, right? And whether it's fixing access or fixing the design of a waiting room, or helping to figure out how to improve staff morale. I mean,
Right.
what I'm hearing is that, hey, like you patients have something to offer here. So let's
Yeah, we
focus
might
on
have
that.
some good ideas. Like, and the idea of engagement is such a silly term, I think. I mean, I've seen the terms change over the years. So I'm not saying engagement is a silly term. It's like whatever. It's on my CV. It's something I do is patient engagement. It's the term that's being used right now. But I am already engaged in my healthcare and my son's healthcare. Like, I am not non-engaged. Like, for the most part, folks who have kind of chronic things going on or being monitored because they've had cancer or whatever, like, we already get it. So who's not engaging us? The system and the people who work for the systems. That's where the engagement falls flat. It's not about me being engaged in my healthcare. So it's kind of a funny thing. I think that I don't want to call this resources, but we're certainly untapped, the patient voice. And I think that a lot of people have a lot of really good ideas if only we were asked. So I think that's where we fall short. And next time I see a conference that's full of health professionals, it's a healthcare conference, and there's not one patient on there, even on a panel, I'm like, oh, I've failed, because I really believe that you are missing a big piece of the picture if you're not talking to patients.
So let's go there because full disclosure, we organize a conference. In the past we probably haven't done as good a job involving patients. I think we're getting better. We're learning as we're going. There are certain conferences that I attend that do a fantastic job. I was just at eHealth in Toronto, and I
Yeah.
think they've done a really good job at involving patients. They were not token patients. They were patients that were up on the stage, on the main stage. At every plenary, there was a patient voice represented on the panels. There was a patient booth, right, where the PAN network was there, and all the patient speakers were there. So I think they did a good job. But what can and should conference organizers in healthcare think about to engage and involve patients in the agenda or at the event?
Well, I think number one thing is compensation. That's something we didn't really talk. We talked about jobs. We didn't really talk about this work being compensated, which is also a very hot topic now, and I'm glad that it's being discussed more. So I'd say about 11 years ago, I went to this very fancy conference. They didn't pay me. They said, "Oh, we'll pay for your hotel as a speaker." I'm like, "Well, thanks, I guess." But I'm getting. Anyways, I was part of a panel, and I was sitting there, and everyone else was a health professional, and I realized that I was the only person not being supported in some way to be sitting, like, nobody was paying me. I'm like on my own, right? And I know other speakers say, oh no, I didn't get paid directly. Well, your work is supporting you to go. So that is like a different way. It might not be direct compensation. I don't have a work that's supporting me to go to these things. So I think the first part is like, equitable compensation, and considering the fact that we travel, we have childcare, we take time off our own jobs, like all these types of things that bring us there. You need to have a budget for that. That's like really, really important. I've had huge conferences that I know have, I look at their registration fee, they got big budgets, and they say, oh, there's no money for a patient speaker. And the other thing is patients need to start saying no. And we have to start recognizing our own value and worth and saying, I'm not going to speak if you're not going to pay me. And that's the end of it. And that's a hard, line in the sand. But so there's the compensation piece. And then there's also, I've worked with events to help support patient panels. You need to have someone supporting folks who are speakers, all kinds of speakers. And the irony of this is I often do plenary speaking now, and I get way more support as a plenary speaker and as an experienced speaker than I would have way back, 15 years ago when I was sitting on a panel, when I actually needed that support even more than I do now. Like, it's kind of a funny thing. And so working with folks to help them feel prepared, help them feel comfortable, understand what the room looks like. People ask me, what should I wear? I don't know what to wear. Like, all this thing. What's the tech like? Going through all that prep stuff, supporting people on the day. And then this is important, especially for Zoom events, debriefing with people afterwards. Because if patients are coming in, we often share our wisdom about the system, but we do that through our own personal, very intimate, vulnerable stories about healthcare. And I think that's not recognized enough, what a gift and how brave we are when we talk about hard situations in our lives to this audience of people who are perhaps involved with making those hard situations, right? So I think that kind of emotional, physical, mental support for speakers, probably all speakers. Plus, speaking is like very stressful. Like, there's anxiety involved with that for everybody. I think having somebody committed to doing that at a conference is really, really important.
Wow, tons to unpack there. I love the idea of speaker support. Um, both I'll call it financially, as you're calling it, compensation, because you're right. I mean, there is sort of the covering of travel costs and those kinds of things. And that's good. I mean, we should at least start there.
Mm,
But to your point, like everyone else on those panels, everyone else who's speaking, they're still getting paid that day of work, even though they're not at work, right? Because their work
right.
is saying
In
that there's
some way.
value in
Yeah.
this in some ways, right? So
Right.
to your point, there's home costs that aren't reflected in just paying for the airfare and the hotel. So budgeting for that, I think, is to your
Right
point.
at the beginning, and not making patients ask for it. You should be offering,
Mm,
if you're approaching a patient right up front, like I don't mind asking for it, but I've been doing this a long time. I know there's a lot of other patients that are reluctant to ask for it because we don't feel we've got the value and work. And this is something, I believe it or not, I've had to work with my husband about, which is terrible. Like I hate that I can't just do this myself. And a lot of this has to do with being a woman, not feeling like I can speak up, being, I was raised to be well behaved, not make a fuss, all that kind of thing. So it's taken me a long time to be comfortable with that. So instead of making us ask, that should be an offer. It should be right at any kind of patient engagement, whether it's a conference or sitting on a committee, it should say that in the description, what the compensation is, so that we can make a decision either way. I mean, I still do volunteer unpaid work for not-for-profits and stuff. It's not like that's totally off the table, but I need to know that in order to make an informed decision right up front. And that's just a professional thing as far as I'm concerned. So people have to know what to expect. I think that that's really important. We're not like nice to have. Like it's like I said, I think we're essential. And so we should be treated like we have the value and worth because we do.
right. And I know there has been a lot of talk about this recently, but that what you're just saying there also extends beyond conferences, right? Like when patients get asked for their opinion on strategy, when they're asked for their opinion on physical plant and all those things, there's value to that. You would have paid a consultant money
Oh,
for that
yes.
opinion.
Quite a bit of
You,
money. Yes. Yeah.
right? Like,
Yeah.
so why not? It shouldn't be odd to think about compensating a patient for that same kind of input.
Right. I
Um,
had I
so
had a group once. I asked, like, I knew they had compensated patients in the past, and I said to them, I was being interviewed after I had cancer. I thought, oh, I should go back and do more engagement work, kind of get back into things. And I said to them, are you offering compensation to the patient members of your committee? And they looked at me and they said, if we offered compensation, it'd be too much like work for them. They said, that's what they said to me. And I was just like, I was like, what? So it's work for you and you're getting paid, but it's not work for me. Like, it's just such a weird disconnect. And you know what? If you don't offer it, you know who you're going to get at the table? Wealthy patients. That's who you're going to get. You're going to get people who can afford to bring themselves to conferences, or to, retired people. Like, you're going to get a thin slice. I'm not saying their experiences aren't important, but you're never going to get diversity unless you offer some sort of compensation. Not everyone wants to take it, but I think that it should be offered. Sorry, I've kind of like taken this onto the compensation. It's about value. It's not real. It is about the money, but it's about value and recognition more than anything else.
frankly, it's about respect, right? Like if you're respecting
Right.
that person's time, effort, it doesn't matter what their title is or their affiliation is, whether it's a consultant or a patient. If you value their time, their talk of compensation shouldn't be odd.
Right. Yeah, that's right. That's a good way to say. And we live in a capitalistic society. Like that's just a fact, right? So like I said, I need to pay for my $9 eggs in some way. I shouldn't have to make an excuse of why I need to get paid. Like, of course, I have a disabled kid. Like, I've got lots of reasons I need to get paid. Like, if you work for a company, you don't make up a bunch of reasons you need to get paid. Like, that's the way it works. Like, you give something a value, hopefully you get paid back.
So Sue, for all of the health executives and leaders who are listening and watching this, we covered a lot of different messages here. What's the one that you would like for them to take away from our conversation?
I would say just two words, and it's better together. And consider the fact that you might not know everything. And that might sound kind of cheeky to say that. I worry sometimes there's an ivory tower thing going on where folks, they're trained to be experts, so they think they know everything, but you can't know everything. And really, engaging both staff so-called frontline staff, people who work at point of care, and patients about their experiences, it can only help you be better. So the better together, and don't be afraid of us. Like, I think people are afraid patients are angry, and I am angry sometimes, trust me. Like, sometimes I am angry, but for the most part, I think most of us are reasonable. We've got wisdom to share. We want to give back. We know that we can't come out punching because people don't listen to us then, right? Like, we've learned over the years how to get our messages across. And so, don't be afraid of us. And I think you can learn from us. That's the one thing. It's a bit of a humility thing too, that maybe you can learn from somebody who is quite a bit different than you. And like, that's totally okay.
So, final question for you. Where can people go to connect with you?
Oh yeah. So you could go to birdcomm.ca is my company URL. I'm on LinkedIn. I really I used to be, I think you and I met on Twitter to begin with, Colin, like a long time ago. So I'm not there anymore. So I transferred all my energy over to LinkedIn. I do try to post every day about patient engagement and healthcare in general. And for those, LinkedIn's very business-like. I try to be like kind of more real there than most people are. But if you're interested in kind of a more personal bend, I'm also on Instagram, and I do a lot of picture posting there. And it's Sue Robbins YVR, which is Vancouver's code for our airport. So, and Robbins, I always say with one B, just like the bird. So I've got a bit of a bird thing. Sue Robbins YVR, that's where I am on Instagram.
See, it's all connected. See, you're totally a marketer, right? The bird comm, the
Yeah.
Robin, it's
I know. It's like if
all
you have
related.
the last name Robbins, you're with one B, you're always saying it's like the bird. So, but my first book's called Bird's Eye View. My second book is called Ducks in a Row. So I think I have actually a bit of a problem with birds. But yes, you're right. It is a theme and they're great. Like, there's so many bird idioms out there. It's such a great thing to use for marketing. So
Lots of
yes.
bird memes. Yes.
Yeah, lots of bird memes coming from me. So thank you for this.
Well, Sue, it's been fantastic having you on the program. Thank you so much for all the information you shared. It's been fantastic.
Yes, thank you. Thank you for your good questions and prepping me beforehand. I appreciate it. So it was a great experience. Good to have this conversation with you, Colin. Thank you.
Boy, what a real conversation. I loved how Sue spoke from the heart and shared her unfiltered opinions on what is going on with patient advocacy and patient engagement. I thought she had great advice on how we have to do more than have a token patient representative on our committees and panels. We need to get to a place where we are co-designing with patients, and we need to compensate patients for their time and expertise. I want to thank Sue for taking time out of her busy schedule to speak with me. I'm Colin Hung. Thanks for watching, and I'll catch you on the next video.